Shall we start now?
Yes, yes.
So good evening to everyone who has joined with us here today. I am Dr. Shruti Patwal from the Medical Affairs team at Universal Nutrascience UNS. On behalf of UNS, I welcome you all to our UNS D3 Ultra-focused CME on M-POX. Today, we are gathered here to gain insights on a very crucial topic, monkeypox, also known as the M-POX. M-POX is an emerging viral disease with significant public health implications. On 24th of August 2024, WHO Director General Dr. Tedros declared M-POX outbreak as a public health emergency of international concern. Universal Nutrascience, a pioneer in nutraceuticals, is dedicated to addressing such global health challenges. As a scientifically driven company committed to advancing health, today's discussion on M-POX aligns seamlessly with our mission to provide valuable insights, fostering informed conversations, and ensuring a proactive approach towards managing emerging health threats. And to support us with this initiative, today with us we have the very well honored, the very well learned and knowledgeable esteemed speaker, Dr. Mradul Kumar Dagga sir. So Dr. Mradul Kumar Dagga sir has done his MD and Masters of Science in Infectious Diseases from the London School of Hygiene and Tropical Medicine. He is currently working as the Professor of Internal Medicine and Infectious Diseases at ILBS. He was formerly a Head and Director of Medicine and Director Center of Environmental and Occupational Health at Maulana Azad Medical College, New Delhi, which is one of the most reputed medical colleges in India. He also has a few awards to his name, like the WHO Fellowship in Critical Care and Pulmonary Medicine, the ICMR Award and State Award for the Best Serving Doctors by Government of NCT Delhi. He's a very learned and knowledgeable person, like I mentioned. He has more than 230 national and international research publications, 30 book chapters. He has delivered more than 400 presentations at conferences and seminars. He's an expert and member of the selection committee for AIMS, PGI, UPSC. In fact, he's also in the editorial board of reputed journals like the Journal of Respiratory Research, BMJ. He was also an editor of an e-learning book and was on the International Advisory Board of Davidson's Textbook of Medicine. He's a president at Naidisha, which is an NGO for the underprivileged children since 20 years. And he was also the chairman of Task Force for the COVID care in Delhi. So it is with great honor and privilege that we welcome you, sir. Thank you so much, Dr. Mradul, sir, for being with us here today. And without any delay, I'll just hand over the entire platform to you.
Thank you so much, Shruti, for those kind words. And I'm really grateful to everyone at and especially Anjali and Dr. Manish for giving me this opportunity. I know. In this evening, in next 20 minutes or so, what I'm going to do is talk to you about this new threat of a global epidemic, which we might expect. And already WHO has declared it as a global health emergency. And so it is very surprising that when talks about this illness, when in Iraq for last 70 years, we have just not seen any case of smallpox. And now suddenly this disease is coming up and spread to most of the corners of the country, of the world. So what is it? It is really a viral zoonotic disease, which are symptoms all typical like smallpox. And many of us not have seen those cases. But luckily, it is less clinical severity. This was first discovered in 1958 in colonies of monkeys who were kept for research. First identified in humans in 1917 in the Democratic Republic of Congo in a 9-year-old boy. Even in Congo, this was eradicated, smallpox was eradicated in 1968. So within 2 years, they found this case there. And in 2003, the first outbreak outside of Africa. So till that period, for next 33 years, It was not outside the African continent. It came with a case reported in USA when a person contacted with infected pair of the dogs. So now over 120 countries have reported M-POX cases between January 2022 to August 2024, and over 100,000 laboratory confirmed cases and over 220 deaths amongst these cases. So most of the deaths are precipitated by this illness in patients with having underlying illnesses. As far as India is concerned, we just last week read about first case confirmed recently from not a new strain from clade, which the strain I will talking to you about. Until 2022, we have 30 cases reported in India. Now, luckily, there has not been any fatal outcome in any of these reported cases till now. So what is this? This comes from a family of Poxviridae, which is, subfamily of Cordopoxviridae, and then a genus Orthopox virus, which is like species like monkeypox virus, and it is primarily a double-strand DNA. So it is a DNA virus. So it comes under the category of a zoonotic viral infection. Luckily, it is self-limiting. Now, what are the two different strains which have still been identified? The clade 1, which is in Central and East Africa, clade 2, which is in West Africa. Now, clade 1 is what is ongoing global outbreak, and it is unfortunately more virulent. Clade 2 in West Africa has been found till now to be less severe. So natural reservoir is yet not completely known. However, certain rodents, including rope squirrels, tree squirrels, Gambian paused rates, dormice, and non-human primates even are known to be naturally susceptible to infection of monkeypox virus. So they may be apes or monkeys or any. Now, what is the incubation period of this illness? Generally, it is 6 to 13 days, but can range from 5 to 21 days. The period of communicability, as with most of the illnesses, starts 1 or 2 days before even the rash appears on the body. And it continues till all scabs fall off or get subsided. So this is a long infectivity period, and that's the source for such vast spread of this global epidemic. Mode of transmission, human-to-human transmission, large respiratory droplets, or you have a direct contact with body fluids or the lesion material which is coming out from these skin lesions, and indirect contact with lesion materials such as through the contaminated clothing or linens of an infected person. And a lot of cases have been reported during sex with person with infectious skin lesions. In fact, in the end, I'll show you one paper from NEGM where most of the cases are through this route. Animal to human transmission by bite or scratch of infected animals, like small mammals, including rodents, rats, and squirrels, and non-human primates like monkeys and apes. And that's why the name monkeypox has been given, or sometimes to the meat preparation of these animals. So very beautifully depicted here, the pathogenesis. You have respiratory droplets, contaminated surfaces, as I talked to you about, mucocutaneous lesions. And once it comes out, there is a viral entry and replication in the oropharyngeal or respiratory mucosa. And this leads to a viral load circulates to lymph nodes, draining mucosa, and primary viremia occurs. So animal to human transmission by bite, as I told you, or blood and body fluids of infected animals, or while you are having an infected meat. Once this happens, within a span of 7 to 21 days, the lymph organs and distant lymph nodes like spleen get impregnated with these. Viral replication occurs, and that leads to secondary viremia, and then that spreads to skin and tertiary organs and causes clinical manifestation of monkeypox. So this kind of a process, as happens with most of the virus illnesses, occur in this as well. So if you want to know this attachment of the virion through the host cell, and plasma membrane fusion with the neutral pH, release of this viral core into cytoplasm, this is what is happening, the attachment, the entry, release of virus DNA. Then a late transcription occurs of leading to mRNA and then translation. Then these assemble, these assemblies which take place in the cell leads to, alteration of this, and then this comes out of the cell. And then this person becomes infective. So nucleus, there where it is taking place, and early transcription, and then translation. This causes the problem. So once this extracellular virion transport and exit the cell, they move to adjacent cells and cause polymerization. And this polymerization leads to continuation of this transmission. So what are the clinical presentation? There is a prodrome of 0 to 5 days. As I said, you may be 6 to 13 days where it may be. But sometimes within 3 days, you may have that. There'll be fever. There'll be lymphadenopathy, typically occurs with fever onset, headache, muscle aches, exhaustion, like with most of the viral illnesses. There may be fever with chills and sweat, and they may have sore throat and cough. Once there is skin involvement, which occurs within 1 to 3 days of fever onset, which lasts for a very long period. So that's why the infectivity lasts for 3 to 4 weeks. There are deep-seated, well-circumscribed, and often develop umbilication. They are also painful until the healing phase, and subsequently they become itchy when there is a crust stage. So if you look into what have there been symptoms in these cases of monkeypox, almost everyone has, this complaint of skin lesion. Everyone, almost 100%. Headache, fever in 88%, headache in almost 80%, pruritus in 74%, lymphadenopathy in almost 2/3, also chills and sweats in 2/3, myalgia almost in 63%, sore throat in almost 50%, and fatigue, oral ulcers, which we'll show you subsequently, cough, conjunctivitis, they are intolerant to light, sensitive to light, and almost 20% will have vomiting, nausea during first 10 to 12 days of this illness. So you have all kind of illnesses, and that really debilitates a patient. So what are the stages of rash in this M-POX? So the first 1 to 2 days, there will be a macule, the macule lesions. Sometimes the lesion first appear on the tongue, and then you see them occurring in mouth, then the macular regions. Then you have papules, which occur in next 1 to 2 days. They typically progress from macule flat to papular raised regions. Then the vesicles appear, which are typically filled with clear fluid. Then they typically become pustular, filled with opaque fluid like this. This is the vesicle, this is the papule, and this is the macule. Finally, lesions typically develop a depression on the center. Umbilication occurs a little bit like this. All right. And these pustules remain for at least 5 to 7 days before they begin to crust like this. And by the end of second week, pustules get crusted, scabbed over, and these scab will remain for almost a week or 10 days before they fall off. So these are very, very typical, of M-POX. Now, what are the differential diagnoses? The first thing which comes to our mind is varicella, chickenpox. Sometimes a disseminated herpes zoster, although disseminated is very, very rare, it is always in a line of a nerve. Disseminated herpes simplex, measles, and certain sexually transmitted diseases like chancroid, secondary syphilis. Rarely it may mimic a hand, foot, and mouth disease, which you may also see in patients post-chemotherapy in a lot of scenarios nowadays. And very rarely like infectious mononucleosis and molluscum contagious. But again, these you need to keep in mind. But when we talk about diagnosis, we will refer to where, how do you rule out these all conditions. So what is your approach? First and foremost is, are you a traveler? Are you coming from an endemic region? Or is there a community outbreak going on? And it is a community transmission that you need to know. Asymptomatic, one needs to observe for development of any signs and symptoms for 21 days post-exposure. If signs and symptoms develop, one needs to collect specimen as per duration of illness. So how do you collect them, which we'll talk about. So in a rash phase, which is symptomatic, the lesion roof with scalpel or plastic scalpel collected in a plain tube, lesion fluid with intradermal syringe. So like when you have already a vesicle, lesion base scrapings with sterile swab, lesion crust in a plain tube, or nasopharyngeal or oropharyngeal swab in a plain tube. And you do collect blood in EDTA and also in patients who have serum glutamic pyruvate transferase solution, media. You can also have a urine culturized media. So during recovery phase, best would be blood collected in the SSGT, what you talked about, serum glutamic pyruvate transaminase media, and urine and sterile culture. Generally, you should collect it from multiple sites. So once you collect them, you send them for a PCR for orthopox virus genus, cowpox, buffalo, camel, and monkeypox. If it is negative, you are almost sure that you are not dealing with monkeypox. If it is positive, PCR specific monkeypox, you don't have to worry. Or you can do a real-time PCR monkeypox DNA isolation, and you report it positive for monkeypox. So once you have this, for research purposes and for finding out clade 1 or clade 2, you can do a virus next generation sequencing. And this sequencing is available only at designated laboratories in our country. NIV Virology in Pune is leading that, but a lot of other institutes have that available. You can visit Ministry of Health and Family Welfare guidelines, and you can see those sites. Now, what are the systemic evaluation you will do for the patient when you have, high risk for those with complicated or severe, when you're thinking it is a complicated or severe M-POX? Please monitor the vitals, oxygen level, level of consciousness. Also look at blood glucose, look at their BMI, even mid-arc circumference, and also look at the pain scale. What is the general condition? Is patient able to eat and drink without support, able to sit and walk independently, or patient within a week has had recent weight loss? Then what is the character of the rash? Very, very important. Which stage? Macule, papule, pustule. Location of the rash, very important. Number of lesions. And based on the number of lesions, that has been categorized into mild, moderate, severe, and very severe. So it is not uncommon to see 25 to 99 skin lesions in these patients. Mild will have less than 25, moderate 25 to 99, severe 100 to 250, very severe will have more than 250. And if exfoliation is present, what is the percentage of body? If more than 10% of the body is showing skin exfoliation, you need to be observant and careful in these patients. They may become dehydrated, they may develop a lot of other complications. Also look for secondary bacterial infections, cellulitis, pyomyositis, necrotizing soft tissue infection. Also look for if they have anything like seizure or coma or altered mental state. Dehydration, very important. Look for that, mild, moderate, or severe. Signs of perfusion, simply by pulse rate, by tachycardia, capillary refill, urine output less than 0.5, and mottling of skin, which all show signs of dehydration. If there is high respiratory rate, more than 22, SpO2 is low, or patient is having accessory muscles in use. Then nutritional assessment, very important, weight loss, and what is the appetite? Does he have any signs of malnutrition? Although this would occur more in patients who have other comorbid illnesses, or cancer patients, immunocompromised patients, or chronic illnesses. And you may need to do all these tests, including electrolytes, your bicarbonate, your kidney functions, liver functions, glucose, blood cell, blood count, platelets, PT-INR, calcium, albumin in a patient who is sick. So what is the management? In a patient who has skin rash predominantly, you try and protect the compromised skin and mucous membrane. The skin rash clear with simple antiseptics. You may sometimes use mupironic acid, mupirocin, and fusidine. Cover it with light dressing if there are extensive lesions present. If do not touch the scratch and lesion, so keep that universal precaution. In case of secondary infection, relevant systemic antibiotics may be considered. If there are genital ulcers because of M-POX, sitz bath, oral ulcer, warm sterile gargles, and oral topical anti-inflammatory gel may be used. If there is conjunctivitis, most of the time it is self-limiting, but you may need to consult ophthalmologist if there is pain and there are discharges. You may need topical antibiotics and anti-inflammatory topical drops as well. Rehydration therapy and nutritional is very, very important, and especially if there are nausea, vomiting, diarrhea, although this has not been reported much. So encourage ORS or oral fluid, intravenous fluid only if it indicated, and encourage nutritious and adequate diet. If there is fever, sponging, paracetamol as and when required. For itching and pruritus, topical calamine solution, antihistaminics. Nausea and vomiting, you can give them antiemetics as well as for headache, again, paracetamol and adequate hydration. So what about using antivirals? At the beginning, let me tell you, at the moment in our country, we do not have these specific antiviral, which I'm going to enumerate next, available. So, but it is only being used under randomized clinical trials. When not possible, antivirals may be used under expanded access protocols, when you have an emergency or like use of unregistered investigation drug. What happened in COVID? When we did not have that, we wanted to use certain drugs like IL-6 inhibitor, like tocilizumab. We took emergency permission for use of those drugs, so that can be done. So tecovirimat is the first drug which has been approved in patients with monkeypox. This is an antiviral drug, but unfortunately, at the moment, not available. There are now other drugs like brincidofovir, we already have in market for other conditions, NIOCH-14, and even a vaccine immune globulin. They can be considered in combination with tecovirimat or as an alternative therapy in certain situations. And what are those? Severe ocular infections, life-threatening manifestations like in severely immunocompromised HIV patients with cell count CD4 less than 200, clinically significant disease progression while on tecovirimat, or those who have recurrence after an initial period of improvement. Resistant to tecovirimat, that is, new monkeypox lesions developed despite more than 2 weeks of treatment, and they are allergic to or unable to receive tecovirimat. So what are the doses? Just for sake of enumerating it, although they're not available, adults, oral or IV, 600 milligram twice daily for 14 days. If person is less than 40 milligram, then 400 milligram. And mainly it acts on the annual protein inhibitor, orthopex PP19. Side effects are pain, nausea, headache, that's all. Brincidofovir more than 200 milligram once weekly for 2 doses. Cidofovir 5 milligram per kilogram once weekly for 2 weeks, followed by 5 milligram per kilogram IV once every other week. You have to be careful about neutropenia, hypotonia of eye, iritis, uveitis, nephrotoxicity, and immune globulin 6,000 unit per kilogram as soon as symptoms appear, may be repeated based on severity of symptom, and sometimes even 9,000 per kilogram may be considered. Again, symptoms, side effects are headache, nausea, vomiting. Antibodies obtained from pool human or plasma of individuals with immunizing vaccine provide passive immunity, like what you were using plasma during COVID as well. So currently, there are some vaccines also recommended, not available with us. Zynos vaccine for risk of exposure to M-POX, including patients traveling to those areas or those who are in close contact with these patients, and those who are immunocompromised, post-transplant, post-cancer patient. The other vaccine is this, also is not been used in the current outbreak. You provide 2 doses, 4 weeks, and then 2 weeks, and that will produce the maximum protection. In certain special situations, like during women during pregnancy, mild or uncomplicated, there's no need for them to be in the hospital. Although, if you monitor them in a health facility, it would be better because then you will be able to ensure isolation also. Severe or complicated, immediately admitted, supportive care and interventions to improve maternal and fetal survival. They should have support to mental health and psychosocial support. And if at all there are maternal and neonatal complications. Mode of birth can be individualized. Induction of labor and cesarean section only when medically justified, like for any other condition, and based on the maternal and fetal condition. If they are recovered from monkeypox, then you received only routine antenatal postpartum or abortion care as appropriate. Additional care to be provided if there are any complications, and they have recovered and they have complications. For infants and young children with monkeypox, just monitor them very closely for evidence of potential congenital or perinatal exposure or infection. Children exposed to M-POX fully vaccinated for age according to the routine immunization schedule in these countries. And feeding, follow the normal feeding practices. Whether to stop breeding should be assessed on a case-to-case basis, considering the general physical status of mother and the severity of the disease. There is no definite recommendation to stop. So the current CDC guideline for monitoring patients with prodromal symptoms, but no rash or skin changes for up to 5 days. If no lesions develop, monkey infection is unlikely and the testing is not advised. So if you have these prodromal symptoms like fever, chills, rash or lesions, no, monitor for rash or lesions, consider other causes. Rash or lesion develop, they do not develop, monkeypox virus testing is not recommended. If they develop lesions, yes. And if they have urethritis, conjunctivitis, pharyngitis, proctitis, again follow the same. If they develop rash, it is consistent with monkeypox. If they already have rash or lesions, then it is consistent. It may be that or recently suspected or confirmed, close contact with epidemiological risk group, or there is a travel history living in endemic area. If any of these are present, then one should test for monkeypox, minimum from 2 lesions, and start isolation if not already started, isolated. If they are not there, consider other DDs and very low threshold for multipox. Any risk for sexually transmitted diseases? Yes. You should screen for syphilis, HIV, HSV, chlamydia, and other. If the monkeypox results positive, yes, then supportive care, notification for close contact, isolation, reevaluate for complication. This is very important. If they are negative, then you have a high suspicion, consider retesting, and you need to follow the laboratory guidelines, which say that if the rash continues to progress, you may do a repeat lesions. So if you have lymphadenopathy and sexually transmitted infection proven, then you need to treat them as well. What is more important is risk communication and preventive measures. So you need to tell the patients to avoid contact with patient and any material or a bleeding, isolated infected patients from others, practice good hand hygiene after contact with infected animals or humans, use appropriate personal PPE when caring for patients. Isolation of the patient in an isolation room of the hospital at home is in a separate room with separate ventilation. Patient should wear a triple layer mask. Skin lesion should be covered if possible and minimize risk of contact with others. Isolation to be continued till all lesions have resolved and SABs have completely fallen off. Let me tell you in final a recent publication 2 years back where they looked into almost 528 infections diagnosed in 2 months at 43 sites in 16 countries. 98% of the persons were gay or bisexual men, and 95% of them came with rash, and almost 64% were having less than 10 lesions. And 73% of them had anogenital lesions. And common systemic features preceding the rash included fever, lethargy, myalgia, and headache. Also, lymphadenopathy was very common. Antiviral treatment was given only to the 5% of the persons overall, and only 13% were hospitalized, but there were no deaths. And these were the lesions you can see. These are the kind of lesions you may say in monkeypox on the oral, on the tongue. Can you see it here? Look at this in the uvula, near close to uvula, tongue, on the lips. Look at these lesions. And if you look at the anogenital lesions, these are the different stages of lesions. Papules, then vesicles, then scabbing, and all those occurs. And these lesions may last for 3 to 4 weeks. So I want to end by saying that you have to be cautious. I have not made a summary slide, but the bottom line is that if you have a strong travel history from the endemic area, and person has prodromal symptoms and a rash, and the rash, the number of lesions are much, much more than what you see in any other rash we have talked about. You need to be very, very careful. Isolate them, investigate them, take a proper history, and please do not create any panic. Thank you very much for your patient hearing.
Thank you so much, Dr. Mridul, sir, for such an enriching and insightful discussion on monkeypox. So we'll just open the platform for a few questions that the participants or the delegates have. And until the questions start coming in, what I would like to know more about M-POX is what are the particular risk factors which is found in Indian patients or Indian population that they are susceptible to monkeypox infection?
No definite, as far as the Indian, whatever 30 cases have been seen. All those 30 cases are one who had history of travel to Africa or some other places. And till now, luckily, none of them had any other underlying comorbidity. So we cannot say, but definitely the whole data is still to be analyzed. The cases have been there for last more than 2 years, and no one has them fully analyzed them. But this for sure, I know that none of them had any cause of sexual transmission, and none of them had any other comorbid illness. So they are just travelers who got this illness. But further details at the moment are not available.
So, sir, as a busy clinician, clinicians these days are bogged down with malaria, dengue, and chikungunya and other conditions. So, why, as a busy clinician, do I need to know about monkeypox and actively look out when I have other cases which are begging for my attention?
You are absolutely right. So, If a patient comes to you in first 2 days of just a URI and fever, you would just not bother about it. But a lot of patients come to you after 3-4 days of these symptoms. And if they at all have any lesion on their skin, and especially on face to begin with, you have to be very, very cautious. And that can only come when you are aware that this is happening. So right now, I know most of our physicians and practicing physicians are not even thinking about it, and they're not even aware about. So you don't take any history of travel in those people. So if you have, my suggestion is that if you have a person coming with fever, myalgia, sore throat, and a rash in current scenario, because with dengue and malaria, the rash is very difficult, very different. The rash comes very late. Here, the rash comes within next 4 to 5 days. And the rash of dengue and all that is very, very different from what you see in, or for that matter, even the rash for your measles is also little different. And you may not have first lesions on your face. You may have first lesions on your hands and your chest and abdomen. So the lesions are much less. The lesions are, but of course, in measles, and I would say even before that in chicken pox, you may have some confusion. So the first and foremost would be chicken pox. But again, the chicken pox lesions are not that many to begin with. They are multiple, I agree. The type of lesions are also similar. But initially, evolving stage, we don't see much. We directly see a papule, we directly see a vesicle, we don't see much macule there. But yes, if you go into depth, you may see that. So only when you have skin lesions, then only you would be more cautious. But by that time, that person might have infected few others already.
Thank you, sir. Thank you so much. So we have one of the questions from, please, sir.
No issue, you can go.
Okay. So, sir, there is one question from one of the delegates, that is there any particular age group who is more susceptible to monkeypox?
No, there is none. There is none. Every category, any age group. If you look into the birth data, most of the cases are in second decade, third decade onwards. But if they are in children as well, they've been described in children as well. So no age group is, every age group is susceptible to it. There is no particular age group.
So, sir, how are the...
What has also been observed is more so common in many of these Western countries in patients who are having sex with men. So that has been one defining point in monkeypox, which is not so commonly seen with other viral illnesses or common illnesses like chicken pox and all. Yeah.
So, sir, how is the mortality rates with monkeypox, and does one need to be worried about the mortality or take it on the lighter side?
No, as of now, there is no need to be worried about mortality. But yes, if an individual has underlying chronic serious illness, he or she might have a poor outcome. The worsening of underlying illness can precipitate this issue. And that's why there are scenarios where even a plasma or immunoglobulin is also being tried. And despite that, so the drugs have not worked very well. So it's almost, I'm not saying that it's like COVID, but yes, it's in a way like that. So if you have that, you may not have a severe ARDS like COVID, but you may have your immunity is so low with chronic illnesses that you have this fulminant virus, and that it may cause you 2-3 things which I told you. Primarily, it may even involve your nervous system. It may involve your GI tract. It may involve your respiratory system. And any of these may go higher and have a secondary bacterial infection leading to a severe sepsis and a poor outcome.
So, sir, countries like Singapore are thinking of vaccination for certain patient group or risk group. So, are we in a stage where we also in India might have to explore that option?
I think Indian government has to think about it because, as I told you in the beginning, at the moment they do not have even the drug available. They have not procured that drug as of now. They have not thought of getting that vaccine also because is a vaccine like for a smallpox similar to that. So even that is not there. But certainly, if in days to come and months to come, if you are not able to contain it, the situation may get out of hand, and then you would require. So one has to think in terms of that. Again, the travelers, they have sensitized all airport health outlets, health, AHPO, which are there at different airports. So at the moment, there is no advisory for screening of these patients coming from outside, even those coming from Africa. So that kind of thing has not happened. So I think if they start getting more cases, they will have to start that advisory that right at the airport entry, they will have to screen them.
Sure, sir. Over to you, Shruti.
Right. Thank you. Thank you, Shruti.
Thank you, sir. Thank you, sir.
Thank
So
you.
we'll just wait for a few questions if they are coming in. Until then, if Vikas sir or Anjali ma'am or Pallavi ma'am has any questions, they can ask as well.
So, sir, there's one common myth which floats around that smallpox and monkeypox are same or they're dissimilar. I understand they are dissimilar, but the common myth is that probably both smallpox and monkeypox are virtually overlap or similar.
Yeah, of course, there would be this common myth because it's almost like, lesions are like pox lesions only. But again, as of now, well, there not been a much reported cases of kind of the severe complications which I've seen with smallpox when it was there. But yes, as I told you from that paper from NEGM also, there was no mortality even in those cases. So, ultimately, what you think in terms of a very worse and poor outcome. So one has to look into what it is. But yes, how it behaves. Is there any chance of mutation here? And again, the two strains, clade 1 is right now in circulation, which is causing more severe, where people are getting hospitalized. So like in the NEGM paper, you see almost 7% people were hospitalized, isn't it? So yes, they needed hospitalization. That means the disease was severe, or the underlying illness was there and which made the disease behave in a manner which was severe and they need to be taken care of. So one has to be very careful about my batteries. So one has to look into this aspect that we have to be on watch, constant watch. And once these cases are reported, in a country like us, they may multiply anytime because the reporting, hiding, reporting is poor. People try and hide, so we might have challenges at that level as well.
So, sir, this disease originated in a lab in US or did it originate in Africa? What are the
No. So no, let's not get into that controversy. It's in US it happened in 1970. I think what year I told you. Yeah, first case. So 2000 something, 2002 or something. I forgot. So the first case reported there, but again they attributed to the meat and all that paired exposure to the dog and all that. But yes, let's not think of a lab explosion here. It's definitely transmitted through the travel and through the exposure. So it has happened like that.
Sure, sir. Over to you, Shruti.
Okay.
So, sir,
So thank you. Yes.
So I have a question, like since we are major, like we are from women health and obviously we have ortho division as well. So just to understand, is there any complication to the baby if the pregnant woman catches monkeypox?
They have not as of reported anything. There is no recommendation as of now, Anjali, I know of that there is a prophylaxis to be given to people who got exposed to M-POX during pregnancy. Is it going to bring about that? That is, I am not aware of any
Yeah.
of that scenario.
Just
But
to
they,
understand,
but
like the medications that are given for the M-POX treatment to a pregnant woman, can they, because a pregnant woman is not
false
supposed to.
teratogenicity and all that.
Yes, sir.
Yes. Yes. So of course, any of these medicines during first trimester can be a problem. There's no doubt about that. But after first trimester, most of them would not have, like other antivirals. But it is individualized. As of now, the recommendations are individualized according to what scenario you have. After first trimester, not much risk, but during first trimester, one would always have a risk.
So any message you want to give? Because I have seen, like, we visit so many hospitals and we have not seen any kind of precautions like we used to see during the COVID times. But here, like,
Yeah,
nobody
so I
is
think
aware that like monkeypox
these
is
are
in
early days, Anjali, and these are early days. People are more struggling right now with dengue, malaria, and even COVID, which keeps on occurring off and on. We are seeing a lot of different viral illnesses also besides COVID, dengue, malaria. I have been in Delhi. We are seeing some very different presentations. So people are more struggling with that. But I'm very sure in years and days to come or months to come, if you don't think about it, already advisories have been issued all over. The advisories issued almost for last month. We received advisory from our hospital administration in third week of August itself, with all those guidelines and all that, what to do and what precautions to do and all that. So I think they are already issued to all hospitals, centers, and all that, but wherever government can reach. But I think mass awareness kind of a thing is still not on. There are no, because they have not seen much cases. But as what happened in COVID, they suddenly multiply within no time. So one has to see. But after that one case, there are no further report in last 5 days from Delhi. So I don't know how is it happening. But my advice is only that if you have fever and someone coming with a lot of raised skin lesions on your face and hands, if there are no other possibilities you're thinking, just do think that take a history of travel, take a history of exposure to anyone who had similar lesion in family or friend. That is very important. And isolate yourself. That is very important.
Thanks a lot.
Okay, we call it a day. We call it a day then. Yeah.
Shruti.
Sure, sir. So thank you so much, sir, for such an enriching discussion and such an insightful session as well. It is only because of these mass discussions or mass awareness programs that we are having right now that, we would be ready for the future that is coming in, and we would be able to curb diseases like these. So thank you so much, sir, for being
Thank
here
you.
today with us, being a part of this initiative, and also taking time out of your busy schedule and, dedicating it to us. Thank you so much, sir. I would also like to thank Nikhil Mehra, sir, who's the Vice President and EU Head of Women's Health, Pallavi More ma'am as well, who's the Marketing Manager, Anjali Sharma ma'am as well, and the entire Women Health team for being with us here today and, ensuring a smooth event going on. And also thanks to RX Events. I would also like to thank Vikas sir and Dr. Manish sir for sharing their inputs and insights from the medical team as a part of the medical team. Thank you so much to all the delegates as well who are present over here. Thank you so much. Once again, thank you so much, Dr. Mridul sir. Thank you.
Thank you. It's been a pleasure. Thank you very much. Thank you so much.
Thank you, sir.
Take
Looking
care.
forward for the collaboration.
Thank you. Thank you.
Thank you. Thank you so much, sir.
Thank you. Bye. I take leave. Nice
Thank
meeting
you,
you.
sir. Good
Yeah.
night.
Nice.
Bye.
Bye.